Can you hear me now?
I can.
Awesome.
Wonderful. Um, well, welcome everybody to our next discussion, which is on neurostimulation, and it will be presented by Dr. Dawn Eliashiv. She is the professor of neurology and the co-director at UCLA Seizure Disorders. So you're on, Dr. Eliashiv.
Hi. Good afternoon. I think I'm starting the afternoon in the West Coast, except if you're lucky and are in Oahu or Maui, then you're probably still somewhere else in the morning, but happy afternoon to the rest of you. So I'm going to present slides, but what I really want to do, since I am going to go review briefly the three currently approved neurostimulation techniques for VNS, DBS, and RNS, and I'm going to give you examples of patients that we decided to give specifically. But what I'm interested is also your interaction, and I want to know whether you have questions. And I want you to try to understand like why we choose one over the other and what should be the expectations. So the order I'm presenting the techniques and the procedure doesn't mean anything about um, my specific preference because I think they're all three very important. But please feel free to ask questions because I think your questions are more important than the actual presentation.
And
Um,
Dr. Eliashiv, I will be monitoring the chat box. So if you let me know if you want me to just
yeah,
interrupt the talk when there's a question or wait
yeah.
till the end.
No, we can, I want to make sure people have enough time for it because I have
Okay.
lots of slides, but the slides are, a lot of them are technical slides and some of them you're all going to have like here specific lectures in the program about all of them. So I want to make sure, but I wanted to give some context to things. So first of all, those are questions that we ask ourselves and the answer to the first one is like, does neurostimulation replace medications or surgery? And I can tell you that usually it doesn't. Basically we're talking about now more of a holistic approach of combining treatments. And some patients can have successful epilepsy surgery, but they still may have to be on a medication for epilepsy. And what we're really talking about is what do we find the best treatment for patients. And some patients, if they sleep enough, or the patient occasionally have seizures like once every few years, which we call a fancy term called oligoepilepsy. Sometimes those patients, there's a debate. Do those patients really need to be treated? And the question I'm going to try to address, actually have you address in between, is like, how do we choose between them? And what I'm going to do in this talk, I'm going to give you a brief overview of the three procedures, VNS, DBS, and RNS, and try to explain why we chose with that specific patient. And I'm a strong believer in active interaction with patients, and I think that patient preference is very important because sometimes for a particular patient, we may offer two of those modalities. So the patient preference, I think, is very important. But in order for you to make an informed consent, you need to know more about things. So, I mean, here you do know that we do have certain things, certain problems that we have. And I always ask the community of people with epilepsy to share information because people don't really know how many people are affected by epilepsy. And I think it's important because I think that you, as patients and caregivers and families, can educate not less than other physicians. So we're talking about 70 million worldwide, 1% of the U.S. population. One of the problems we do have is that sometimes medications don't help, and people that have failed like three medications, their chances of being seizure free are quite low. And another thing that there's been a lot of awareness is that we do have a lot of mortality. There's the sudden unexplained death um, in epilepsy. And then, especially in patients that don't respond to medications, that rate is high. And what I can preface and say is that all those neurostimulation modalities have shown effectiveness in reducing the risk for sudden unexplained death and epilepsy. And how many times you are have medications and patients are like frustrated that certain medications don't go. So there is a treatment gap, and one of the aims of this conference is to do education and to lessen that treatment gap. And we want to maximize treatments. And one of the things that we can maximize treatments is like sometimes patients are offered surgery or afraid of surgery. Sometimes patients can have epilepsy surgery, and sometimes they don't want to have epilepsy surgery. So the question is, and whether with these patients, which of those patients neurostimulation can be. So just to show you that something it's not new, it's something that's been around. So a lot of those some of those people were born in actually 2 centuries ago. And the question is, and that's why the field has really evolved, is like we have many options, theoretical options of where to put electrodes and where to stimulate. And I'm going to show you that everything has a particular purpose, and we can look and see. And this is like a short, a brief cartoon showing to you with regard to epilepsy, like there's deep brain stimulation, because people want to know where are things implanted. So I think that this cartoon um, shows basically um, the differences of what to expect. So if you are looking at the vagal nerve stimulation, you're having this device and it stimulates the vagus nerve, and the vagus nerve has afferent pathways that go through certain areas of the brain. The thalamus, places fancy names like locus ceruleus, and affects the brain. If you look at responsive neurostimulation, you're actually having a device. The device is placed under the skull, and you're attempting to stimulate a particular area in the brain where we think the seizures are starting. And when we have deep brain stimulation, the approved procedure is putting in targeting a place in the thalamus called the anterior nucleus of the thalamus. There are some people implant other areas with deep brain stimulation, but the approved one is implanting over that. So randomly, I'm just going to give you principles and examples of what to expect with and what are the principles of it. So let's start with RNS. And the reason I started with RNS is there are a little bit less patients with that, but it's totally random. I flip around things. So this one, the RNS device, as you can see, this is the device itself. Uh, it's only approved if you have like identified two specific regions of the brain, either one or two, or you identified an area of the brain which does not you can't touch with surgery because it's close to language or motor, um, and and that's another principle you have here, and this is called open loop versus closed loop, which basically means that this device has a seizure detection. So the seizure detection works on identifying that specific seizure patterns of the patient, and puts an electrical stimulus. So just to give you like an example of what it does, it only has a few channels. So there are only like 8 channels that it can record activities. So you can't put like 100 channels, and those you've either had it or had family members that had implanted electrodes in the brain, whether stereo EEG, depth electrodes, or grids. You can see you only have 8 electrodes total. And what you can see here, it detects like a change between the regular activity and what looks like seizure activity, and then it stimulates. Obviously, it needs to be placed in the right place. And what we're talking about, we're still working about getting approval for teenagers, but the initial indication is for 18 years or older. So that already gives you a differentiator, although there's some off-label patients that have been implanted with RNS. It's only for focal seizures or partial seizures, depending on the whims of our new international, it's not so new anymore, the changes in the International League Against Epilepsy defining how epilepsy. So again, you can look and see what are the common patients. You can look at it. If you have seizures that are coming from the temporal lobe that are both, um, then that's something that is a good indication for it. If you know that all the seizures are coming from language areas, and I can give you the patient example that I'm going to give you, um, it has that particular, then obviously that area can't be resected, and that's another consideration. And another area that's become very popular now in the field of epilepsy surgery evaluation is a place in a deep structure of the brain called the insula. And that deep structure of the brain called the insula is hard to resect. There's has a lot of blood supply and has a lot of neurological complications with resection. There are some people that resect it, but the most common approach for it, if you know the seizures are coming from there, and you have insular epilepsy, and that was a type of epilepsy that was like underappreciated for many years, because sometimes we thought that these were temporal lobe seizures, but those patients could have had like sensory disturbances on one side of the body, sweating, autonomic signs, and afterwards, that was the beginning. And afterwards, the rest of the seizure looked like a temporal lobe seizure. And we did surgery on some of these patients, and they didn't respond. And now when we do studies that we target with stereo EEG depth electrodes, that area, we find out that those patients are some of them come from the insula, and that's a deep structure with a lot of blood supplies. So that's another example of a patient where we would recommend RNS versus other surgery is not an option in that particular case. But if we know that all seizures are coming from the insula, that's an example of a patient that we would choose. And that goes, is it safe to resect, not safe to resect? What are going to be the side effects? Um, Obviously, resective surgery is curative in some cases. And all the neurostimulation procedures are currently considered palliative. Now, it doesn't mean that we don't have like 10 to 15% of patients that may be seizure free. Uh, but again, it depends on how many areas. If you identified 1 or 2 areas, then RNS could be an option. If we feel that the seizures are starting multiple areas, then maybe the patient RNS is not a good option for this particular patient. So that's something that we know. So let's go and give you an example of a patient. I've shown the slides many times. I have tons of other patients. We have over 100 patients at UCLA, or approximately 100. I don't want to give wrong fact without fact checking the right information, but around 100 patients that we've implanted. But I still like giving this example as an example of a patient that did respond to RNS, and let's dwell on it, and we can and see why we decided that RNS is a good option. So she's 26, and her seizures started at age 17. And what we found out in this particular patient is that she had nausea lasting for 1 to 2 seconds. And what she had afterwards was speech disturbances. And we divide the inability to speak into either receptive or expressive um, dysphagia. And it's hard sometimes with a seizure because people stop talking when they have seizures. So it's something that's really hard to know whether it was receptive or expressive. But we felt that that was like more receptive because her perception of words and music and everything was gibberish. And some of those seizures, even though they lasted only for a few seconds, she did have other seizures that became generalized, or as we like to say in the new classification, evolving to bilateral convulsive. And I apologize that we always sit down and have classifications. And there are very bright people that go over these classifications. But remember one thing that I think I prefaced it in a few slides before is that that one of the awareness, there's a lot of awareness now to sudden unexplained death and epilepsy, and we do know that that's a risk in patients with drug-resistant epilepsy, and we do know that all these modalities of neurostimulation reduce the risk of seizures of with sudden unexplained death. So she's on a lot of she has lots of seizures, more around the menstrual period, and she's tried multiple medications. And we use now, instead of anti-epileptic medications, we call it anti-seizure medications because of like that. So I'm going to just go over and just um, give you certain things. So we did a routine EEG. This is a routine workup, and we found that her seizures are coming from the left side and the back portion of the left side. We did in the epilepsy monitoring unit, we found that her seizures are coming from the left posterior temporal region. So we did a functional MRI, and we can show it to you later. But basically, she's right-handed, left hemispheric dominant for language. So even if everything comes from one area, that's a problem. Is that area resectable or not? We did the MRI, we did a PET scan, and we didn't see anything, which is not unusual because a lot of times patients have, and these are beautiful images showing the MRI and the PET, and basically nothing. And then we did another test that's called an MEG, which is looking at the brain's own magnetic activity. And with this test, since we have we have brain waves, like EG measures the abnormal electrical activity, and MEG measured the abnormal magnetic activity. Now, these are very small, and for those of you who probably everybody's familiar now with Tesla, so there's so much noise around the world, so we have to put, in order to measure those small magnetic fields, we have to put patients in a magnetically shielded room. And there's like micro, milli, so these are femto Tesla, which is like nine nine orders of magnitude. So these are very small magnetic fields, and you need very specialized equipment to look at it. But what we can look here is that when we model the magnetic activity of the brain, we see that it matches. It's over the left posterior, a lot of abnormal spiking over the left temporal, posterior temporal region. So we ended up putting electrodes, and I'm not going to bother you with technicality. And then after we put electrodes, we said, oh, okay, we have a problem. It seems like that her seizures are starting over the language area. And we did a functional MRI, which sort of like also did that, but we didn't give up. We say, let's do put in electrodes on the brain. Let's do a grid and see whether those electrodes, whether language is really over that place. So that's what we ended up doing in this um, particular with this particular patient. So that's what we did. We looked again at the functional MRI. Okay. Doesn't look good. Language area seems exactly where the seizures are starting over. And we actually did language mapping, which where we stimulate with small electrical pulses, we stimulate areas of the brain. What we're looking for is if we give a small electrical pulse while somebody is like trying to recognize an object. If they don't recognize that object, that usually means that it's an area associated with language. And we saw that there were language problems over that area. And this is like where we put the electrodes over, um, this is a cartoon showing where we put the electrodes on the brain. So, flattened out. I'm not too good in presenting you holographic three-dimensional images, maybe in the presentation 10 years from now. Um, and what we see is that it was like exactly the same. And we found actually that unfortunately the seizures and where the seizures started and where language is exactly the same thing. So we can't resect that area, obviously, because it involves language. It comes from one very discrete area. So what we decided on this particular with this particular patient is since we know exactly where the seizures are starting from, so we wanted to stimulate an area where the seizures are starting from. We saw that the seizures on the EEG and on the study that we did with invasive electrodes, it started in the same place. So what we decided to do is to put the RNS device on this particular patient. And this shows you an example of this particular patient. And it shows, and we put the two strips in this particular patient. And what it does, it gives like 5 pairs of pulses when it recognizes a pattern that looks like the patient's typical seizure pattern. And with this particular patient, what we found out is that we had um, almost a 99% seizure reduction. One of the problems we had was okay, she's on a lot of medications. Um, and that's another consideration is like, okay, she's almost seizure free. Uh, she's young. She may be in childbearing age. What do we do next? And that becomes like the balance is do we take the risk and reduce the medications? And so I'm just giving you that example, just that example. Yes, it's a great outcome. Doesn't happen in all the patients, but that's something that we need to take into consideration as something. So this is an example of a patient um, with that had a great outcome. If you want to look at where the outcomes are in general, so this shows you like long-term follow-up on the patients. So you don't expect that in every patient, and patients always like ask, what's the data? So about 3/4 have a reduction in 50% in seizures. 28% had at least one period of greater than 6 months without seizures. Why did I use 6 months? There are many ways of cutting the data. As far as driving, um, which maybe is less important now with COVID-19. But hopefully, driving is very important, and I'm a big advocate for telehealth too. But it is the quality of life. So you look at it, and one of the things that I try to do, and I should do a better job, is managing patient expectations. What can we expect? Our aim is always to have no seizures, no side effects, but we have to be aware of what the patient expectation is. But this is the data, but this is something that you see in all the neurostimulation effects. It becomes better over time. And I think that one of the things that we're learning over time is that we're still learning. I mean, these things we're still learning. Even VNS that was approved since 1997. We now have like surrogate heart rate, and we'll talk briefly about that in another patient example. So there are always things that we are learning. So I think that now that we know how to program better, and we're learning like how to increase the stimulation or set the parameters, we are actually seeing that in the patients that were not part of the pivotal trials. Pivotal trials means the trials that were used to get the drug approved by the FDA, that's something that we're learning more. So we're getting better with more experience. I'm from UCLA, just to show you that, that, and this is across centers. So we had in our outcome, we had a median reduction of 70, and this is an older slide by now. We have many more patients. But again, you can, just to show you what the expectations are. Yes, there were 7 patients that were seizure free. There were 8 patients that had a remarkable response to seizures, but the others, some of them had a response, some of them are not. And, outside of the scope, what we're trying to do is like trying to, and NeuroPace is trying to use big data to see which patterns are, how to identify who will respond versus who will not respond, and what is, if you're looking at million EGs, which pattern is the best pattern for that we can tell the patient personalized medicine. This is what we're looking at it. And again, one of the things that, everything is different. But one of the things that I want to go over is that you don't stimulate the whole day. So even with RNS, you're talking basically just about 6 minutes of stimulation. I have patients with VNS that have wonderful outcome. But, VNS, typically you start 30 seconds on, 5 minutes off. You change it over time. And some patients after a while have great response. But I just wanted you to know, because that's something that patients ask, like, how many am I going to be stimulated all day? Because, they say, oh, it picks it up 3,000 times a day or 4,000 times a day. It picks up some changes in activity. So what are we talking about? And just to show you that it works in lots of places, but it doesn't change from time to time. So again, and this is something that goes with a lot, all of the neurostimulators without bias show improvements in quality of life. And one of the things with all the neurostimulation is that the SUDEP rates are decreased. And I can show you with VNS, DBS, RNS, and other people will talk about each specific system. So I don't want to too much time, but you can see that there is a significant decrease in SUDEP rates, sudden explained epilepsy. Now, one can say, okay, is it the device, or do we, because we have a patient has device, we see them more often, we're more alert. The patient is an active participant, has a seizure diary, calls the physicians more often. There are lots of other things that you can ask, but I do think that that's very important to look the risk, and they will discuss it later. So, obviously the surgical procedure, so there's some risk of infection, but it's really like that. So let's move forward to DBS. So DBS, is deep brain stimulation, and again, um, the reason I'm showing this complex slide here is just to tell you, yes, DBS is good for seizures, but the strategy is a little bit different. You implant an area of the brain called the anterior nucleus of the thalamus. And the reason I'm putting all those structures around it is that if your seizures are coming from both temporal lobes, or they're coming from the cingulate, or coming from the front portion of the brain, those are the areas that are important, because if you stimulate an area, you have to know what the network is. And for those of you who have been going to the American Epilepsy Society or going, there's a lot of emphasis on the networks and what is an interaction um, for each patient of the network. So that's something that I think is important, is to know if you're putting implant in one place, you're not just affecting that particular place, you're also affecting the network, and that's part of the principle of implantation of deep brain stimulation. But what's approved right now is anterior nucleus of thalamus. I know there's some off-label things. Um, People can implant in other areas like the central median, and there are other series, but the approved indication is the anterior nucleus of the thalamus. So it was based, Bob Fisher is giving a talk today, I think on a very important epilepsy talk on something else. And I always admire that they came up with those things. So, all those trials were done in 2004, but it took many years to show you how long things get approved. It was actually approved in Europe before it was approved in the United States, but deep brain stimulation is now an option also for patients with epilepsy. And just to show you like how hard it is to do trials, initially we implanted 110 patients, but you can see here is that you have like obviously some people, all people were implanted, but some had the device on, either got current when they were programmed, and some got sham current, but everybody else. So this is just to show you like at 7 years, because obviously you want to know so what happens with these things. So you can see here, so each bar graph represents a patient. So you can see this on the left side is the patients that did well, and those on the right side are patients that did less well. But you can see here that a lot of patients did very well, and some patients had like seizure free, which is over here, and some other patients had variable degrees. So you can see here that the results after 7 years show that it's effective. And again, the same principles. It gets better with time. So a lot of the patients come with VNS or DBS or RNS, and sometimes they say, oh, it's been 3 months since I've been implanted. Maybe we should look at something else. And it takes time to get the effect. Again, it's a surgical procedure, so there are infection. There were some people initially, and that's another thing that we've learned over time, is that initially when things were ramped right away, and obviously with VNS, you also don't ramp right away. Patients that were ramped right away had more depression than patients that now that we know that we have to start gradually, and we don't run away. Some patients in plant had hemorrhage, but the hemorrhages were very, very small and not of clinical significance. So just to show you cartoons, and you're basically implanting stereotopically, which means there's like computer aided targeting devices. And obviously I'm a neurologist, not a neurosurgeon. I don't implant them personally. But I think that one of the things that has advanced over the years is our targeting is much better. We don't do blind targeting. We know where we're going. And this structure of the brain is very small. So basically we need neurosurgeons that are experienced that know how to target small areas. And there's a new device called the Percept, and everything now is going to be programmed with milliamps, similar to the other devices. You know, the amplitude will be similar, but basically, what you're receiving with DBS is like a 1 minute on, 5 minutes off, and it is there all the time. Now, it doesn't use like it's not closed loop, which means it doesn't detect the seizures. It just works all the time. Although the new device, the Percept that is recently approved, has a surrogate marker. And why am I going to surrogate markers? Because this one may have low field potentials, LFPs, and VNS uses heart rate. So there are other ways um, that are available in order to do that. And again, people do it slowly. And I want to show you an example of a patient, and I don't want to run out of time. So, but basically, it just shows you that we don't program right away. We implant a patient, and then we can program a few weeks later, like 2, 4 weeks later, we start programming. And I usually have patients come back. So you can have them come back after a month or after 2 months. And you have a seizure diary. So I think it's very important to have a seizure diary in all these patients. And this is just showing you where things are. And you can see here, like, um, a picture of this is like a small, it's like the depth electrodes that some patients have implanted. And this shows you the area of the brain that it's implanted, which is in the thalamus. And we're talking about the anterior thalamus of the nucleus. So you can see here, you can put one on the right, one on the left. And there are 4 electrodes. Most of the times you just do it from choose one electrode, but again, you can be creative, and choose things. And um, and I think that nowadays, since especially with COVID-19, one of the things that I like about, also with the DBS and the VNS, is that with VNS there's the auto ramping feature that the FDA approved. So if you go by a certain protocol, the patient doesn't need to come back to clinic. And with DBS also, and especially with a new device, you can actually give some control over the patient, that we can up or lower, up or down the parameters, which I think is nice. So this is the older device that we've used, and this is how it looks. Just if you wondered, everybody gets laptops, computers, which is kind of nice. And these are the usual parameters. And for those of you who are following target voltage, I can start with 1 volt and then go gradually. And I think that now we're shifting with the devices to milliamps. So this is where you're talking about, and I think it's important for patients to know more or less what the milliamps are, what their settings are, not to be oblivious to settings. I think it's very important, because I'm a very big proponent, as I told you earlier, of active participation with patients, because I think one of the things with epilepsy is that patients don't always feel they have control. You have a seizure, you have lack of control. So having patients as partners and giving them some ability of control, let's go over a Zoom visit and change the parameters a little bit. I think that that's something very important. Again, everything has side effects. Some patients have paresthesias. We talked about, if you ramp it too fast, some patients had depression, some patients had sleep disruptions. And again, a lot of those patients are still on medication. So that's something you have to take into considerations. There are certain things with devices. If you need certain surgical procedures, think about it. People will talk to you later, but I think with all devices now, you can have under certain conditions, MRIs. Airport, haven't seen one in some time, which is very unusual for me. Uh, but yeah, just tell the screener. And this is just an example of their new stimulator, which has a surrogate. You can measure actually local field potentials, and there's still a lot that we can learn about it. So let me give you an example of a patient, right? Because we need to see patients. Um, and so, um, so this is a 34-year-old patient, and he started having seizures at age 15, and he had um, autism, and there were behavioral, had kind of like seizures, like so. See about it, like one seizure, he had facial pulling type of seizure, facial pulling to the right, another pulling to the left. So we already have like two types of seizures, right? So it's not one type of seizures, and the patient had seizures monthly, failed, or actually, I should say the medications failed them, um, multiple medications. And we did a workup, and we found out that the seizures, we had like came from what seemed to be both temporal lobes. The MRI was normal. The PET scan showed, some changes over both temporal lobes. Um, Neuropsychs showed a little bit problems with like memory, but more of like picture naming and things like that. And we did also the magnetic activity, and you can look here and you can see here, and I'm not going to expect you to see, but there's a little bit lighter colors here. And if you look here, you can see blue. So blue is like less activity, red is more activity. So you like to see things symmetric. So it was like there was too much blue on both sides, but on a large area of the brain. So we don't know where, there are multiple areas of abnormality. Doesn't seem so good. And then I'm not going to show you. I cut some of the slides. Anyway, we put electrodes inside the brain, depth electrodes, stereo EEG by the common jargon now in many other centers. And we captured lots of seizures, but we really couldn't pin it down to two discrete areas, right? So remember, like, we looked, and this is like the magnetic activity of the brain. We can see it. It's bilateral, and that activity, because it's bilateral, um, um, and that's bilateral. But again, okay, we don't know where the seizures are starting. We see it like on both sides. And I'm not going to go too technical, but if you see just one thing on one side, and it's not like a cluster, like everything clustered, that's a lot of times not enough to go forward for surgery. So obviously, it wasn't a candidate for resective epilepsy surgery. We looked VNS, DBS, RNS, and we decided that in this particular patient, we don't know where it is, but the seizures still sound like they involve the temporal lobe, okay? But we don't know where, but we're not sure whether it's the middle temporal lobe. We're not sure whether it's the outside of the temporal lobe. We're not 100% sure that these are not seizures coming from the frontal lobe, because of the seizures, some of the seizures that we did when we did invasive electrodes. So we don't have a nice, simple two places coming in a discrete area in each temporal lobe. So we decided that this patient would be a good candidate for deep brain stimulation. And we look here at deep brain stimulation, and this is like showing the MRI and showing where we put the electrodes. And we only put two, but you're chronically implanting two electrodes inside the deep structures of the brain. And I just gave you dates here just to show you, like, in real life, what happens? You implant March, you do the programming April, you come back, and a month or two later, and this shows you the screen. They're cool laptops and shows you how many volts they are. It's just, and I'm not going to go too much, but what you need to know, it's 1 minute on, 5 minutes off. Patients usually don't feel anything. You actually ask them if they feel anything, but you don't. So this one is the patient. And we did follow up on the patient. We increased it a little bit from 2 to 3, and you can see how it looks on the computer screen. And sorry about this high that. So this patient was seizure free, like for about 8 months, 9 months. Then March had um, a single seizure. Now I don't always increase after one seizure because there are other reasons, sleep deprivation. But March was the beginning of COVID era, and I knew it would be harder for me to change things. So I decided to increase it. Although one of the things you could do with DBS is you can pre-program it that we can give the patient the ability together with us to change the parameter. But this is another example. Now, VNS, you're going to have wonderful talks, I think, from Deborah Holder. I saw she's going to give like an excellent talk on VNS. So I decided I'm not going to do too much. So it's been available since 1997, includes pediatric indications. The others, like, you can have a 4-year-old and implant VNS that's on label, but I'm talking predominantly about adults. Had zillions of patients implanted, so obviously there's a mode, and you're going to get separate talks, but basically the thing of there are like 3 modes. It works all the time, so you don't need to know whether seizures are occurring or not occurring. That's a common misperception. Oh, do I swipe it? So that's the magnet mode. You can swipe. You don't need to activate the magnet mode in order for the VNS to work, because it always works according to what we call the duty cycle. What's new about it, and you'll hear more about it from Dr. Holder, is that it also has an auto-stim mode. So some measurements are direct, like I can put implant. I can say to you, "Oh my God, somebody is anxious." So what happens when they're anxious? Their heart rate goes up. But we do know that with seizures, also the heart rate goes up. So um, so it captures the heart rate and looks at sustained changes. So not just if we exercise, but if there's a rapid change in the heart rate, it recognizes it and stimulates. Um, so this is what's new with VNS, and Dr. Holder is going to discuss with you. And I wanted just to say it does have SUDEP reduction like everything else. It has great for COVID-19 auto ramp, so we can pre-program multiple steps. And the new device has also like more minute changes. So I think that that's important. And again, this shows you that it can detect seizures by looking at the heart rate. It has a potential to stop or shorten the seizure. And I'm not going to go over too much, but you can see that the new devices work, and that's one of the this we have great neurosurgeons. All of them are awesome, but I always like, why do we need to use the new device? So there is some data to suggest that the new device may be more improvement. Again, like everything else, there's improvement in the quality of life. There are pivotal studies showing that VNS is better if we obviously it doesn't affect like drug, but again, we can see that there's reduction in the SUDEP rate, which I've seen so many patients with SUDEP that even if I can avoid one tragedy for one family, I think it's worth it. And this just shows you, like, this is the standard ramp up. All of us may have a little bit differently, but the principle is you first ramp up the milliamps, the output current, and then you, at the second stage, you make the duty cycle, which means have the machine on off more. So just to give you a brief example of a patient, I'll do it really fast. So she's 22. She had a history of seizures from age 2, and she has multiple seizures types, staring spells, followed by bilateral convulsive seizures once a week. Bilateral convulsions is generalized tonic-clonic seizures, and patient tried on current multiple medications, and she was like on levetiracetam, lacosamide, and clobazam, tried giving names. So she was admitted to the epilepsy monitoring unit, and I cut down some of the slides. Routine EEG showed, oh my God, it starts all over the right. And when we, looked at the EEG, well, it wasn't really localizing. We did an MRI epilepsy protocol. We didn't find anything. We did a PET scan, and we found some subtle changes, but would you really want to operate or go with an invasive EEG based on subtle findings? That's a question we ask ourselves a lot of times. An ictospect was non-localizing. We injected during a seizure because during a seizure there is a change in the blood flow, and we did that and we didn't find anything. And then we also did the MEG, which didn't that. So we didn't have enough information we didn't know where to put the electrodes. And the patient is still high risk for SUDEP, so we don't want to leave her. And she's not a candidate for RNS because there's no clear, we don't find one or two areas. And she's also was concerned of brain surgery, and that's a consideration. Some patients, VNS and DBS may be an option, and some patients, no, I want something in my neck. I don't want brain surgery. So that is also a consideration. And just to show you, the patient was we proceeded with VNS. The patient was implanted in 2018. And we did the standard programming. And and this is typical, no change in seizure frequency, but the reduction in seizure duration is very faster recovery. That was what was the outcome initially. 2019 is reduction of seizures 40%, and I still think that she'll get better. And then again, the drug indications. She wanted to wean herself gradually off clobazam because she was concerned of future teratogenic, what pregnancy was a consideration, and the side effects. So this is just gives you sort of a comparison between the three sets, but I think I tried most of the time to do that. And I do want to give some point for questions. So I'll just end with this conclusion slide. So these are options. So neurostimulation is palliative, manage expectations. I brought you some good cases. Yeah, there are 15% that become seizure-free, but not everybody. Patient preference is very important. If you have a patient with temporal lobe seizures bilaterally, you can choose sometimes between RNS and DBS. Some patients may choose VNS. If you have a patient with LGS and drop attacks, yeah, VNS is probably the option that you should go for. All modalities have reduction in sudden explained death and epilepsy. Improvement over time occurs in all three modalities. And I think it's important, quality of life is important. So if somebody has prolonged seizures and they're out the same day, so even if you just have the same number of seizures, but the seizure severity is reduced and the post-ictal stage is reduced, I still think that that's a worthwhile outcome. Anyway, thank you so much for your attention.
Right now, Dr. Eliashiv, we don't have any questions in the chat box. So if anyone does have a question, please go ahead and type it into the chat box, or you can attempt unmuting yourself and ask Dr. Eliashiv the question directly.
And if you don't feel comfortable right now, don't be afraid to ask later, because I really think that knowing what the options are and thinking about it, it's a shared decision process.
Still no questions?
Okay.
So Dr. Eliashiv, just a quick question.
Sure.
When is it appropriate for a person that's still suffering from seizures and has had one of these procedures to determine that maybe it's not really working for them, since it has such a long duration of effect?
Usually with neurostimulation, we're talking about 1 to 3 years. And again, one does not exclude the other. And another thing that I didn't mention is some patients may have a combination of, if you have a VNS, it doesn't mean that you can't have a DBS or RNS. So I have some patients that have tried VNS and that didn't help. And they've tried, doesn't mean that they can't try another medication or another device. And I have patients that have both. And there's some patients I know of that have all of them.
Thank you. Well, I just want to double check before we end the talk to make sure that there's no other questions. If anyone does have a question, please type it in the chat box or go ahead and hit your unmute button. Or I can unmute everyone, and if you're having a problem, just let me know.
If you can just unmute everybody just for a second, just to
okay.
Anybody has anything?
That's what I'm trying to do. Yeah. It's not giving me the ability.
I'm muting myself sometimes.
All right, well, I don't see.
What are you trying to do, Adriana? You let me know.
I was just trying to unmute everyone, but I can't seem to.
There should be, let me see.
That's what I thought, but I can't find it.
I thought there was an option.
There's just, it asks me to unmute each and like to ask the individuals to unmute. Well, thank you for joining us today, and hopefully your questions were so well answered by Dr. Eliashiv's talk that there were no extra questions. So thank you for being with us, and enjoy the rest of your Awareness Day.